Hi, good afternoon. Welcome to the second of 5 complimentary webinars on the CPT system. Somebody mentioned to me the other day that they thought I was going to talk about the CPT, but no, this is not about behavior therapy. It's about the current procedural terminology. As you may recall from our last presentation, this is about coding, billing, and documenting professional psychological services. The first webinar, which was done approximately a month ago, focused on the basics of the CPT system. And today we're going to do something quite different, and that is we're going to jump right into the CPT process, focusing on historically the most important and by far the largest of the CPT codes involving psychology and mental health. So what I'm going to do next is I'm going to basically share the screen that I have with you, and we'll begin the actual slides. Just a couple of quick nuances. First is I am not still able to accept questions throughout the broadcast, so we will take questions towards the end. You're always welcome to also send me an email, and I'll be glad to attend to this as soon as I can. And then in addition to that, we have printed or we have the link in the website for the certificate that you can download at the end of this presentation. One more thing people have asked me, and I'll mention at the end again, the original website, psychologycoding.com, has the first of the webinars, and we will post this second webinar as soon as we can do so technically. So with that, let me go ahead and begin to share the screen with you. Okay. Okay, so our webinar is entitled Mental Health Services. And of course, I have to go through the usual stuff, the disclaimer, which essentially says I'm doing the very best I can, but when it's all said and done, you have to be responsible for this material. Among other things change so very quickly. Many people and many organizations have been involved. I cut my teeth with my state organization, the North Carolina Psychological Association, and I've continued with a very strong relationship with APA and Medical Association. Many other individuals have supported this, including the clinical neuropsychiatrists. Many individuals have also been very supportive. At APA, more recently, has been Randy Phelps, and in addition to that, Norm Anderson has been very, very supportive of our work. But the staff also have had a large number of volunteers, including probably our biggest unsung hero, and that is James Georgialakis, as well as Neil Pliskin.
So can you, it's not shared.
Okay. It looks like we're not sharing this, so we're going to escape and get back to it. There we go. I think we're in business.
Just a minute.
Yeah, here we go. All right. So apologies for skipping one particular step, and I think we're back on in the saddle, so to speak. The important thing that I want to mention is that everything I say is, I hope, the latest and the greatest, but when it's all said and done, it does not trump the APA Ethics Code, the provincial and state psychological associations, basically state of the art, the regulations, and so forth, so on. All right, so now let's say one more very large comment, and then we'll go to the specifics. Everything that I say basically has to do with what I believe is happening at the federal level. But all those contracts that you and I have signed, they're basically for font. We haven't read. Those trump everything that we have to share with you. So if things don't match, try to make them match. This is, if you will, aspirational and not actually technically correct in each and every one of the several hundred people that may be listening to this particular broadcast. All right, this is, of course, copyrighted material. It's copyrighted by the American Medical Association, even though the CPT system, for all practical purposes, is essentially a concept of the CMS, or Centers for Medicare and Medicaid Services of the federal government. So to get into the actual activities that we're going to talk about today, or the specifics, there are about 8,500 codes, of which about 70 are applicable to psychology. There are many different sections that we could sort of live in. We've historically lived in psychiatry, and over the last 20 or so years, we've moved not only to expand within psychiatry, but also outside, including the central nervous system codes and the like. Those will be attended to at a subsequent webinar, or actually several webinars. But today we're going to focus only on the first one, and that is psychiatry or mental health. And it's hard to tell you exactly when it started. We believe it began somewhere in the 1970s, and the other ones have been added in the last several decades. However, the focus today is going to be about what has happened since the major changes occurring in January 1 of 2013. The academic interpretation of this is really complicated, and I'm going to just go through it really quickly because I want to focus on the most important things, which of course are the actual codes and the use of those codes. Every 5 years, CMS has a review of large set codes that are being used on a regular basis. And we were requested to try and address those codes. Those codes were briefly addressed in the RVU for a number of reasons. That is the actual valuing of things. We decided that that was not going to be appropriate. A working group was actually put together in 2011, of which I was one of the members, as part of the CPT panel. And then subsequently, eventually, an advisory work group that included nurses, open group in the sense of inclusion, and for that matter, a very positive working relationship. This is the actual difference in the CPT process. This is about as thorough, as careful, as comprehensive of a change that really that I've been involved in, and that has been since the late 1980s. So in the approximately 30 years, 25, 30 years of working in the CPT, this is the most comprehensive and thorough approach to changing the code set as I've ever been involved in. And these are the actual representative groups that you can see. It included the standard folks like the psychiatrists, psychologists, but also others, including the pediatric group as well. The last time there was a big revision about 20 or so years ago included 44 code. The current revision includes 11 new codes, 4 code revisions, and 27 code deletions. However, all things being equal, it does bring to a total of 42. Just to put it in perspective, when CPT changes its code sets, it actually does so in a very small amount, maybe 2, 3, 5, but never 42. This is one of the largest revisions in the history of CPT process. And if you can imagine how hard it is for you, it's also similarly hard for the CPT system, which is not entirely ready to make so many codes change simultaneously. This was presented to the panel, that is, a work group presented it to the panel in February 2012. Actually, that was in Tucson, Arizona. I remember that meeting very clearly, and I must say with some difficulty. And then subsequently it was passed, which essentially made this the bread and butter for anybody involving in mental health. And as you'll see in this particular slide, slide 17, we have basically psychiatric diagnostic interviews and then the psychotherapy codes. I'm going to focus first of all on the psychiatric diagnosis because this is actually the beginning of any kind of activity involving work that involves a diagnosis that has DSM attached to it, at least for the next few months. We don't know for sure what's going to happen with the ICD, but for right now, this is essentially a DSM activity that we're talking about. And of course, eventually it'd be anything involving emotional disorders rather than, if you will, the traditional, quote, organic or maybe neurocognitive disorders, which come outside in the ICD-10 system. So this is a particularly big change because we're not necessarily used to this. First of all, we've gone from essentially 2 codes, maybe 3, that is 20, 45, and then the longer one, to now having one that starts at 30 and continues on to 90. Essentially, the 3 most common are 3, 30, 45, 60, and the add-on, the extra one, I should say, not necessarily the add-on, is the 90-minute add-on because it came after the original 3 and not necessarily part of the core of the different psychotherapies. And then one thing that's very, very different is the concept of intensity. We have historically not had intensity as part of the psychotherapy process, but this adds a new flavor. Let me explain to you the reason for this. This is actually something that I was particularly interested when I was on the original work group to develop the psychotherapy codes, and that is that unlike other forms of healthcare, psychology has been bounded by codes that were almost exclusively unidimensional and not much in the way of any profundity. It was either this or that. However, we all know, both in terms of the research literature as well as clinical experience, that psychotherapy can have varied faces. And in this case, I tried to emulate the concept of the evaluation and management codes, which is basically the bread and butter and the holy grail of medicine, which essentially is the standard follow-up procedures that occur in a typical healthcare visit, and where you have 5 levels from very minor to very intense. We ended up with 3 levels, which you can see from this particular slide, slide 18, as standard, interactive, and crisis. I'll talk about all 3 of them. So the psychiatric interview is essentially standard or complex, if you will, interactive, and now we're going to go into the actual interviewing. This is the old 90801, or what we used to call psychiatric interviewing, and some people have asked me, if it's called psychiatric, do you have to be a psychiatrist to use this code? No, the code has this name partially because of its historical reasons, but this code is available to anybody that by state law and licensing, as well as, if you will, insurance reimbursement contracts, allows you to perform the service. So if you're doing an interview on a person in order to obtain a better understanding of their emotional condition, this is the code, and that code is 90791. Now, let's dissect some of these slides, because these slides are often taken from verbatim from the CPT code book. This is obviously to report a psychiatric diagnostic interview or evaluation. However, note what it has to be about. 1, psychosocial assessment, including history, mental status, and recommendations. That's the content. The other thing that's interesting, and this is very new, the evaluation may include communication with family or other sources and review of diagnostic studies. Historically, we did not include the communication with other members of this individual's, if you will, extended social network, or the review of diagnostic studies. In this case, it's become extremely robust code in that it allows for extended communication and review, or if you will, non-face-to-face activity with information that would help understand, as you see earlier, the integrated biopsychosocial assessment. If you are a psychologist and you live in most of the states in the United States and, of course, territories as well as provinces in Canada, you would end up using 90891, which, as I mentioned earlier, requires a history, a mental status, review and order of diagnostic studies, and recommendations. This is really critical. I'll emphasize this several times, both this particular webinar and several others, that you have to link the activity to whatever's going to come next. That is your job. Just finding out what's wrong is insufficient. What do you do with that information to link it to either other services you will provide or other services other professionals will provide. If you happen to be a psychologist in, for example, Illinois, New Mexico, and Louisiana, or a psychiatrist, you're eligible to use 90792, which essentially is involving assessment of prescriptions and actually prescribing itself. Both these codes are used for diagnostic service, but it's important. You cannot report them on the same day as any other psychotherapy services. Okay? If you do that, there'll be an internal edit used by the insurance companies that will kick that out, and you will get a denial, most likely of the higher paying service. The other thing that's interesting is, as I mentioned earlier, that you can exchange information with other individuals or informants, including family members, nurses, etc. And this is a critical issue. The reassessments are permitted on different days. If there is a significant change in the individual's behavior or, if you will, emotional status, you can re-evaluate the patient. And you can report more than once when separate interviews are conducted with a patient. So, for example, if I do an interview on Monday and then subsequently I need more information on Tuesday, that could be reported on 2 separate days. So we have a code that is robust in terms of multiple things. Other individuals being interviewed, review of records, and being able to do the evaluation on a number of days if required. Now, a big question remains, what is the history? Well, you should obtain a psychiatric history, if appropriate, chemical dependency, family history, social, treatment, and medical history. Maybe we should change medical to health history because that's a bit more comprehensive. But in addition to that, you may want to review the systems, especially if you're doing the E&M psychiatric interview code. You may want to take a look at safety, aggression, competency, and finally, you should have a mental status. If you look at psychologycoding.com, you'll see a comprehensive mental status examination from the earlier 90801, and that might give you a rough idea what is it that you're supposed to cover under these circumstances. And of course, the diagnosis, which might include the actual diagnosis, personality, contributing medical factors, so forth, so on. I'm sure this comes as no surprise that this is basically our 5-axis from the DSM. Most importantly, you must include the treatment plan, including what kind of medications you might want to suggest, psychotherapy tests, informed consent for treatment plan, and so forth, so on. Something has to occur to improve the body part. Technically speaking, if you do not suggest what this information will do, technically speaking, you have not completed a psychiatric interview. In essence, to kind of summarize, we have a 90791, which is the standard interview that most of us will do, and 92 if you're involving any kind of medication. Now, this is from the old code set, and I don't want to emphasize this because it doesn't apply, but this is something that's now become public record, and I thought I'd share with you. This is actually the typical activities that should occur, which include, as you can see, greeting the patient, report, reading vital signs, and so forth, so on. Interestingly, it turns out in the old 90801, there was a significant amount of time involved with the nurse in doing things like reviewing vital signs and so forth, so on. Obviously, this is not typical today, and hence this particular breakdown is not what you normally would see. But I do want to point out to you the last particular row here that says we have pre-4, intra-44, and post-9. So a fair amount of time for psychiatric interviewing involves time before and time after. Now let me take a quick breath and focus on really the core of what most of us are doing on a day-to-day basis to earn a living in psychology, social work, or counseling. That is, of course, psychotherapy. This is a table that I put together that essentially tells you that we have brief, regular, and extended, as well as standard, interactive, and crisis. And note, for example, that I bolded the middle of all these boxes, which is 45. So The typical activity should be standard and 45. All right, what is psychotherapy? It's treatment of mental illness and behavioral disturbance in which the physician or other qualified health professional, which is what most of us are in this webinar, through definitive communication, attempts to alleviate the emotional disturbance, reverse or change maladaptive patterns of behavioral, and encourage personality growth and development. Now, remember, attempts to alleviate. Attempts. You don't have to get results, but you should attempt. And sometimes alleviating may actually mean slowing down the erosion of the emotional state. There's new psychotherapies in all forms of settings. However, your insurance form may require, and it's probably not a bad idea, to indicate where this was done. But for all practical purposes, no matter if it's in or out, it's all the same. Psychotherapy codes are basically from 3.2 through 3.7. And I want to emphasize something that I've said several times with the psychiatric interview. It may involve a family member. I will tell you, this is between you and I, that I think in the next 3 to 5 years, we will change the word family to probably something like informant, which could be a family member, it could be a significant other, or somebody that could be simply an informant. Another thing that's particularly interesting and new, and I think somewhat robust, relatively speaking, is that the patient does not have to be there for all of the service. It could be there for some of the service. So you may end up seeing the mom of a child, the caregiver of another person. It doesn't really matter. You can see the patient and someone else. Somebody asked me recently, how long? That has not been defined. We're not clear if it's 1 minute or has to be most of the time, but theoretically it could involve several individuals. All right, so again, 30, 40, and 60 minutes are the ones that are most commonly, and the choice of code is not based on the reimbursement rate, but one is actually closest to the time. And of some note, psychotherapy cannot occur until you at least reach 16 minutes. So the codes are as follows: 3.2, 30 minutes, 3.4, 45 minutes, and 3.7, 60 minutes. Keep in mind that 3.2 has a range, 16 to 37, 3.4, 38 to 52, and 3.7 is theoretically over that period of time, 53. So here's the information, and about as clear as I can give you. Now, there is different issues regarding 90 minutes. Now, we have a prolonged service code that I'll share with you. Alternatively, you can use the 60-minute code and add a 22 modifier. So you would put, for example, 90837, and then the modifier -22. All right, so what could be part of the record? Okay, objective information might include interval history, what's happened since last time they came in, how the patient feels, mental status changes, stressors, coping style, and the application of ranged psychotherapies. I apologize because there should be one more, and that's the outcome of that. And for that matter, the disposition. So add 2 more, and let's make sure that slide 37 is changed for the future, that it reflects what needs to happen. So application of psychotherapy is the beginning of what should be the results, and finally, the disposition. You can use a prolonged service code, and that if you do that, you can use the code 99354 all the way to 99357. However, if you do have access to E&M codes, do not use this code with E&M services. An extended psychotherapy is essentially codes from 354 all the way to 356. And I'll share with you more specifically because it's a bit complicated. Now, let me say one thing because it's important as I go on to the next section, and that is, until recently, it appeared that you could not do 2 kinds of psychotherapies in one day. And that has now been removed from the edit system, and you should be in a situation where you're good to go. Okay, so what happens in psychotherapy? I shared with you the idea of pre, intra, and post-service. Pre-service involves the review of a record, communicating with others. Intra-service is what you and I would consider a typical psychotherapy activity, and the post-service is theoretically what happens after the activity. So essentially pre, intra, and post-service. But emphasize this, that for all practical purposes, you only get paid for the actual time that you spend face-to-face with the patient. In the actual development of the vignettes for these codes and the amount of reimbursement for the efforts provided by the professional, it's important to appreciate that pre and post-service are wrapped up into it. So it's not like you're getting taken to the cleaners with pre or post-service activities. It's already in the vignette. So the system has already taken that into account, but the delivery is basically all about what's face-to-face. So here's one way to look at it. The old psychotherapy code, that information is now public, and you have that as pre is 1, intra is 15, and post is 4. So you can see there's a fair amount of work outside of the actual face-to-face time. So for those of you who are wondering, how do we come up with a value? We actually have done serious studies and where we determined that the average psychotherapy encounter involves 0.05 boxes of Kleenexes, 0.25 assessment devices, and 1 couch and 2 chairs. If you do group psychotherapy, we are assuming that you are using 8 chairs. Believe it or not, this is really as simple as I can tell you how surgery is evaluated. How many sponges, how many scalpels, and so forth, so on. The same applies to psychotherapy. So as you can see from this slide, the psychotherapy code numbers are 90832, 34, and 37. Now, let's talk about interactive complexity, which is an entirely different concept, something that we have not historically addressed in the history of coding for psychology and mental health services. And that is, if you do more than average, if you're working harder, then theoretically you should add 90785. Let's talk about this. Interactive complexity is basically anything that complicates the delivery of a psychiatric procedure. I want to emphasize, just because it's called psychiatric doesn't mean you can't do it. This is essentially either the actual interview or the psychotherapy encounter. Now, this is a very complicated slide, and I want to emphasize 4 points. Interactive complexity occurs if you have 4 simple things. 1, maladaptive communication. 2, difficult caregiver. 3, a sentinel event or maybe a mandated report. Or 4, you have to use an interpreter, play equipment, physical devices to communicate with the patient. 1, maladaptive communication. 2, difficulties with caregivers. 3, sentinel event. Or 4, the use of some mechanism to allow communication. It may involve family and may be reported more than once. Now, let me jump into crisis. This is an entirely new concept for many of us. If the patient has a crisis state, you use a different code altogether. That's 39 and 40, 90839 and 90840. Let's look at the next slide. It's a very complicated slide, and it comes down to this. If the problem is life-threatening or complex and requires immediate attention, crisis is the code that you need to use. And as you can see, it involves anything from psychotherapy to mobilization of resources, anything that you do to decrease the likelihood of that life-threatening or complex situation getting out of hand. Now, an interesting question might arise is, life-threatening to whom or complex to whom? So it doesn't matter if you think so or if the client or patient thinks so. Either one applies. Like some of the things we mentioned up to this point, I want to emphasize several things. And one of them is the patient must be present for all or some of the service. So in other words, you don't have to have the patient there for everything. If you're calling an ambulance, if you're dealing with significant other on the telephone, that's all billable time, and the patient does not have to be present. In addition to that, it does not have to occur all within one day. Theoretically, crisis could start today, and it could continue till tomorrow. This slide describes in a very simple way what you're supposed to do in terms of documentation. You have to basically do three things: history of the crisis state, 2, have a mental status examination, and disposition. We're assuming, for example, like surgery, that this will be done retrospectively. So it's not like you need to have a Panasonic laptop on the side of the curb as you're talking to the patient and they're banging their head and putting down the notes. This is not meant to be that way. This is meant to be retrospective and for you to come back to a particular place, such as the office, and generate the report. These codes are time-based, and I want to emphasize, first of all, that the base code, as I shared with you in the first webinar, it's the 90839, and that is required to be up to 30 minutes. Excuse me, up to the first 74 minutes, and then after that, you have the 39 code, which is 30 minutes thereafter. But the 39 code begins with an event that spans up to 30 minutes. So you can't have a crisis, which is bizarre, but that's how we put this together. A crisis cannot occur if it's less than 30 minutes in length. After that, you then do to the base code an add-on code, which is essentially 39. Okay. Now, the psychotherapy codes cannot go together with the the psychotherapy codes cannot go together with the crisis. And it's important to appreciate that if you start a psychotherapy and it becomes a crisis, by all definitions, it's a crisis. Okay. Again, the pre-service involves triage. The intra-service is what you do with the patient, and the post-service is what you do after the client is no longer in your presence. Now, to add to our discussions, but not necessarily to complicate the picture, we have the family psychotherapy codes. And for all practical purposes, things have not changed since they've been around, so it's not particularly new. And you see that the code that is most typical is when the patient is present, and that is that you have to have the patient there for some or all of the time, and that would be code 90847. If you have multiple family, you use 49, and it's rare to report 46 because, as a rule, insurance companies do not necessarily pay for patients not being present. If you do group, you can also consider the traditional group psychotherapy code, which is 90853. Now, unlike what you've done in the past, this is indeed new. You can use the add-on interactive complexity code for 90785. So, for example, if you have one of the, quote, 8 individuals that are giving you a hard time and you have to calm them down and that disrupts the activities of the group, then the add-on code 90785 would be entirely appropriate. So I mentioned to you earlier, and that is that the NCCI edits for psychotherapy are now, for all practical purposes, attended to, and you can do multiple types of psychotherapy. So outside of individual psychotherapy in crisis, you can do individual psychotherapy and group psychotherapy. I mentioned this several times, and I want to bring back one more time because this is a new concept. And that is, you can do psychotherapy with other individuals that help understand the emotional condition of the client. So if it involves obtaining information, talking to the spouse about how difficult the husband or wife might be, or the partner, all things being equal, that is part of the equation. So here we go. And we have the psychotherapy codes, that we mentioned, as well as these other ones. Psychoanalysis is one of the ones, but it's not typically used. And of course, it depends on whether the LCD covers it. Let's go back and address the issue of prolonged psychotherapy, because this is not as simple as it might appear. It's a new concept for a lot of reasons. The first and foremost is 99354 allows for the activity of psychotherapy beyond 60 minutes. And if you want to do extended psychotherapy, you have, if you will, the 99355, which allows on, to put it in simple terms, the add-on code to the base foundation code of 54. This is essentially to try and deal with individuals who are basically dealing with trauma, difficult individuals, and so forth, so on. When we came up with the original psychotherapy codes, the only information available to us that we used to establish the new code set was Medicare. The Medicare data set has very few 90-minute activities. As a consequence, we had to go back and come up with a new code, and this is the code for psychotherapy. You may still use the 60-minute code and the -22, or if you will, the modifier, but this allows you to do more accurate description of what the activity is. However, and this is why I bring up the -22 as a possibility. However, the 5.4 and 5.5 codes, in case you haven't noticed, are in the 9.9 series. The 9.9 series are evaluation and management. That set of codes is, as I mentioned earlier, the holy grail of medicine. And if you're not a physician, which we are not, as I mentioned to you before, we had two opportunities to become physicians. One in 1964, when the Medicare bill was introduced in Congress, and again in 1989. For reasons that are complicated outside the scope of our discussions today, we chose not to become physicians. I hope we can resolve that. But for now, because we're not physicians, technically we are not allowed to use the evaluation and management codes. Now, I know some people do. For example, some prescribing psychologists do so in Louisiana. That's outstanding, awesome. However, for most of us, this is outside the scope of our accessibility to insurance program reimbursement. So with that set in mind, this is as aspirational as I'll get today. And here we are, 354. And the basic code, or as I said several times, the foundation code is 30 to 74, is 99354. And then if you do more than that, 74 to 104 minutes, you can do it one time, 454. If you do it beyond that, 55. And if you go over 105 minutes, you see how it's done. So it's a complicated system of using both a foundation or base code and an add-on code. So for those of you who are wondering, what does this all mean in terms of payment? Well, it comes down to RVU. In fact, one of my students just signed a contract with Wake Forest University, and the contract appears to be RVU based. The idea is you have to produce RVU activity. This is how all large institutions are going. So in essence, this is the wave of the future. And you see the RVUs in the third column, and finally the payment on the fourth column. And I've emphasized this before, and I'll say it one more time, do not code by column, code by service. So do not look at the fourth column and decide what code to use. You use the second column, which essentially tells you what code is appropriate for you. So at this particular juncture, I do think that the individual therapy, and for that matter, group and family therapy, are going to be changing. So the last slide, which I share with you, it's not a static slide. It's a slide that will continue changing as we go forward. To summarize what we have at this particular juncture, so we have the interview, we have the psychotherapy, and we have the crisis. And we have interactive complexity and psychopharm management. In essence, what we have here is the diagnosis by RX by complexity. So you can do the interview and then the psychotherapy, and you could add interactive complexity, which is the add-on code 90785 to either the interview or the psychotherapy. If it's psychotherapy, it could be for the 30, 45, or 60. Since the interactive complexity is tied in to the psychiatric code, it does not appear that it crosses over to the prolonged service code. It might be, but at this point does not appear. We have new interventions, something that's entirely different. One is crisis psychotherapy, and of course the other one is the psychopharm. I will tell you that the psychopharm has not been valued by CMS. So it's a state by state and carrier by carrier. However, it does allow you to begin to consider the application of prescriptions by non-physicians, specifically psychologists. So we now have a code. I will also add, just in passing, that this also gives you the opportunity to either use the psychopharm code, which can be found in psychologycoding.com, or alternatively, you can use E&M codes. I think it might be easier to use these new codes, but having said that, keep in mind that many insurance carriers are not either accepting them or, as CMS has done, not valued them. So they are still unstable and require additional assistance. Now let's move on to some issues. One of the difficulties that's emerging is the problem of 60 minutes. Some individuals have mentioned to me that they've been doing 60-minute psychotherapy all their lives. Well, the fact of the matter is, for whatever reason, most of us have been coding 45. So 45 is considered the standard of all psychotherapies. And I know for a fact that CMS has noted that there's a large and unusual increase in 60-minute coding, and I would not be surprised that we will see increased audits for those of us who have been doing 60 minutes, which is not to imply that you should not do 60 minutes. If the patient is coming from far away, if there is a complication, if you require a great deal of effort to establish rapport, those are all totally appropriate. And those should be done as one would, and just simply document that information. The difficulty also mentioned earlier has to do with the so-called 90 minutes of prolonged service code. It's very difficult. I'm not entirely sure what to tell you, because you may want to consider the standard psychotherapy with a modifier of 22. For example, it would be 37-22, which would be an extended psychotherapy encounter. Or alternatively, should you consider the prolonged psychotherapy code or prolonged service code, which includes psychotherapy? It's not entirely a psychotherapy code. It's actually a prolonged service code. And that code could be more robust, but maybe not as likely to be reimbursed. It's something you need to clear up with your insurance company as you decide how to deal with these complex, maybe trauma cases. Okay, this comes from my colleague Gordon Hertz, who came up with this interesting data. He actually did some mining, and here we have the psychotherapy. You see the large amount of psychotherapy activity of the 45, 60, 45, 50-minute variety. And notice that the charges, this is unbelievable. It's probably one of the fascinating things about this slide. The charges for psychotherapy range from $27 to $730, with the mean being 131. The interview go from $20 all the way to almost $1,500. So you can see that the psychotherapy and the psychiatric diagnostic interviews are quite a bit. And it appears that the number of providers from the Medicare system in 2012 are approximately 18,000. But as you can see furthermore, most of us who are providing Medicare services are doing psychotherapy. If you want additional information, by all means, you can do so in the slide set in this particular one, as well as the extended one. We have the different links to information regarding the changes in the code and the interpretation of those codes. I also want to make sure you understand that this information will be available in the psychology coding website as soon as we can download it and upload it, if you will. And then the original number 1 presentation that was done approximately a month is already on there for you viewing pleasure. In both cases, you can just do the actual slides, or if you prefer, you're welcome to have the audio video portion. And the certificate will go up and stays up through the beginning of August. And you can see the link, but we'll also provide another link in a few moments, which we'll share with you. So just to give you an update, we will have 3 more of these webinars. One is health psychology, and the other one will be on neuropsychology, and that would be August 31st, neuropsychology, and September 28th. And then we'll talk about emerging healthcare paradigms. Just today, I just heard about the new PQRS evolution, and it looks like we're moving into something called MACRA. And before long, we will be phasing out PQRS maybe by 2018. And this is sort of the standard for all CPT activities. It's almost like a categories test for those of you who know something about neuropsychology. As soon as you learn the paradigm, they shift the set. So hang in there, do your best, and we'll see what we can do to keep you abreast of things. Some resources are available. Here they are. And in addition to that, I also want to tell you that in psychologycoding.com, we have some sample forms that you're welcome to download and use as you see fit. If you want information from AMA, here is the link and the telephone. And of course, don't forget, if you're not a member, to join APA. And if you just left APA, remember this is the organization that works for you. Association Advancement of Psychology. And of course, you can contact me as well. So with that, we will stop sharing the slides and we'll minimize. Okay, and here we are again. And let's see if we can get the Q&A. So it appears that we may be disabled. So I apologize for doing that. However, you can provide comments, and let's see whether we can attend to your concerns. Okay? And I do not know for sure how we can do the comments. So hold on a second. What's that?
Nobody's asked any. No one's asked any questions.
So no one has asked any questions at this point. It was so unbelievably clear that everybody got everything attached to it. So no other questions at this point? Could you please type them in the comment section? And that way we'll address them.
I'm typing back.
And I can type back for you. Now, I will start with one question, and that is the crisis code. Look carefully at the crisis code because in retrospect, I think I may have told you the slight differences in the time, but they're pretty straightforward, and I think as long as you keep up with them, you should be in a good position to be able to find out exactly what is required. And the other thing I want to emphasize, which I said several occasions, keep in mind that the standard psychotherapy is, at this particular juncture, 45 minutes in length. If you do more, it's like 60, or for that matter, any more than that, by all means, please do your very best to document the information in such a way that it justifies that. A third point I want to emphasize again is the importance of linking the current activity to the next activity. In other words, you cannot, in your own, provide, if you will, your interpretation without justifying what's to come next. I want to emphasize that justifying what's going to happen next is, if you will, providing a puente or a bridge to the next activity as a means to making sure that you have medical necessity for the next activity. Now, one other thing that I want to also emphasize as we're waiting to fix the technical difficulties with the questions, I also want to emphasize that you may want to look at the old 90801 documentation suggestions that I have in the Psychology Coding website. And in addition to that, add to that maybe the new information that's available. Maybe an amalgamation should bring a hybrid. You're also welcome to download the Psychology Coding website templates and then adapt them. But I do want to say something about SOAP notes. I think the name implies exactly what they might be, a little slippery on documentation, because it's not entirely clear in a standard SOAP note what is the actual condition of the patient, and more importantly, two other variables. One is what actually transpired. What was the activity, whether it was supportive psychotherapy, CPT, whatever. And then we have two other areas. What happened as a function of the activity, and finally, what is the outcome? In other words, what's the disposition for the client? What's going to happen as a function of what's next? So one thing you might want to do is consider, if you do or you're wedded to SOAP notes, making sure that you understand that you should have what's the status of the patient, number one. Number two, what you did with the patient, what kind of intervention. And number three, how the results emerge. Did they cooperate? Did they understand? And finally, and maybe and foremost, what is the next activity that needs to happen? More psychotherapy, referral to a psychiatrist, stop the activity, etc. Okay, with that, we have some questions. So let's take a look. Okay. I get paid for 90846 quite frequently. It's very rare that a policy specifically excludes it. Excellent. You're very lucky, and keep on doing it. Okay. No other comments? Okay. All right. Well, I appreciate very much the opportunity to spend some time with you this afternoon. And let me encourage, especially because we've only had a couple of questions and we've answered them as best to our knowledge, that you take the time, if you want to send me an email at puente@uncw.edu. That's the email that's easier for me to access, the university email, even though I'm giving you this webinar from my prior practice. And I'd be happy to answer the questions as best as I can. Until then, I hope I see you at APA. If you see me, why don't you stop by and say hi? Otherwise, I hope to see you at the next webinar, which will be on health psychology, the new paradigm for including psychology in all of healthcare. Thanks again. Have a good day. Hope to see you at APA. Take care.